So welcome you all, right? So today we are going to discuss on vitals. So what are vitals and how do we check them? So vitals are some necessary signs which are often measured or identified using some instruments. And with that instruments you can know about the vital status or the general health of the patient. So vitals consist of 5 important things, which include blood pressure, right? So pulse and temperature, jugular venous pressure, and what else? Respiration. So what is the kind of respiration? What is the depth of respiration? Is it a paradoxical respiration? Is it thoraco-abdominal or abdomino-thoracic type of respiration? There are different types of respirations. And these things, any abnormality or pathology in these things can tell you about the health status of the patient. So the first and foremost every doctor must know is pulse. So how to check a pulse, right? So there are different pulse, there are different sites where you can check pulse. So first of all, the definition of pulse must be ingrained in your brain. Yeah? So what is pulse? So pulse stands for alternate throbbing of the arterial wall that occurs because of alternate contraction and relaxation of the left ventricle. So whenever left ventricle contracts, it pushes some amount of blood into the peripheral circulation, and when it relaxes, the same amount of force with which it pushes ceases. And that is the reason why the arterial wall expands periodically depending upon the pulsation of the left ventricle. So that is one important thing about pulse. And so because pulse is present almost everywhere in the body, now where do you check pulse? That is important. So pulse, you check pulse in those areas where it is easily accessible. The most common example of checking pulse is, so this pulse is radial pulse. Okay? So sitting is also very important, how you sit during examination. So when you sit, your legs should be on one side, on patient's legs should be on another side. If I sit like this, and if she is a female patient, this will be an awkward arrangement, right? So sitting is a very important phenomenon while you do any examination, be it an ENT examination or examination of pulse or be it any kind of examination, right? Okay, so I would like to examine his pulse. So for examination of pulse, you would like to find the radial artery. So for finding radial artery, take a handshake. So do a handshake with the patient, and while you do the handshake, what you need to do is you need to do a slight ulnar flexion. So if you check this, this is ulnar flexion, whereas this is radial flexion. His radial bone is in this side, whereas his ulnar bone is in this side. So do it in slight ulnar flexion and slight palmar flexion. Okay? So do a handshake, ulnar flexion and palmar flexion. And what it does is it relaxes the tendons around in the ventral aspect of the distal forearm, right? And then try to find the radial pulse. Okay? Now you can find radial pulse using 1 finger or 2 finger or 3 finger. Expert can find even using 1 finger. But if you use 1 finger, it might be some difficulty for a beginner to find the pulse. And that's why people use 3 fingers. Because when you use 3 fingers, you form a sort of a straight line. And you know the course of radial artery is also in this way, right? So you align your 3 fingers, straight line formed by your 3 fingers in a straight line parallel to the artery, right? So you can do it among your friends as well. So when you do that, it is very easy for you to find the pulsation, right? Okay. So how will you check or what to find when you find the pulse? So what else to notice besides the throbbing that you can feel? So within pulse as well, you need to find the most important thing is pulse rate. For pulse rate, you need to do full 1 minute. Yeah. So take your time and count the number of pulses in full 1 minute, and that is your pulse rate. So if his heart contracts around 80 times in a minute, his heart rate or pulse rate is 80 beats per minute. Although I use the word interchangeably between heart rate and pulse rate, they are not the same. Some persons can have a heart rate of higher, 100, 200, 300, whereas pulse rate only 100 or 200. So that means every contraction may not lead to a pulse. Sometimes heart is contracting, but the contraction is not enough to cause a pulse. Yeah. So there are some pathological conditions like atrial fibrillation, atrial flutter. When heart is contracting, your heart rate is very high, but it is not enough to generate a column of blood to move through the arteries, and that is the reason why there can be a deficit between heart rate and pulse rate. So that is one pathological examination which is in atrial fibrillation or atrial flutter. Okay. So first thing you notice is pulse rate. Normal pulse rate is around 60 to 100. Pulse rate less than 60 is bradycardia, pulse rate more than 100 is tachycardia. So normal is 60 to 100. Even if for some person has a tachycardia, the pulse rate might it might not be a pathological tachycardia. So the most common cause of tachycardia is physiological tachycardia. Can someone give me the example of physiological tachycardia? Exercise. So there is a physiological tachycardia during exercise. Anything else?
Coffee intake.
Okay, sometimes caffeine intake can also cause tachycardia. Anything else? Anxiety. So in this situation, you might feel or he might feel a little bit anxious, and it is very natural for him to have a slightly high heart rate, right? Anything else?
Smoking.
Smoking can cause. So is smoking a physiological condition or pathological condition? Yeah. A physiological habit for some person, but as a doctor, we should consider smoking as a pathology, right? Besides this, so in anxiety, right? In excitement, during fear, during just before vivas, you can have a physiological tachycardia. Besides that, all the tachycardias are pathological tachycardia, right? Okay, so first you notice the rate. Then the second thing is, what do you notice in the pulse? The second thing is you notice the rhythm. So is the space between the two pulses constant in every pulse or not? So that is what rhythm is. So if your pulse rate is something like this, so there is a rhythm, right? But if your pulse rate is something like this, so there is no rhythm to this. So this is irregular rhythm. So the second thing that you notice is rhythm. So rhythm can be regular, it can be irregular, right? So normal finding is regular rhythm. Abnormal finding is irregular. So irregularity can also be a regularly irregular or irregularly irregular. So regularly irregular rhythms are seen in it is seen in atrial flutter with variable degree of AV nodal blocks. Whereas the classic example, the most important example for any doctor is of irregularly irregular rhythm is atrial fibrillation. So this is a life-threatening condition, an atrial fibrillation, where the rhythm is irregularly irregular. You cannot make out any rhythm to it. It's completely chaotic, right? So that is irregularly irregular rhythm seen in atrial fibrillation. Okay. Okay, so that is rhythm so rate, rhythm, and the third thing that you notice is character. So what is the character? So for today we will only talk briefly what is the normal character. The normal character of pulse is something that is called catacrotic. So normal pulse is catacrotic in character. Okay, so that is character. Besides that, there are variable characters. So we will talk some other day. So anacrotic, diacrotic, pulsus bispheriens, pulsus bigeminus, water hammer pulse. These are different findings. So we will talk some other day. And the third thing, the fourth thing that we notice in a pulse is pulse volume. Very good. Pulse volume. So how big a pulse is, right? So if a person is suffering from shock or severe dehydration or hypotension, then the pulse volume may be low, right? So in such conditions, if the person's pulse volume is low, which is also known as hypokinetic pulse, the word kinetic refers to the volume. So hypokinetic is low pulse volume, hyperkinetic is high pulse volume. So hypokinetic and hyperkinetic are the different pathological side of the volume of the pulse, right? So for volume of the pulse, you can check in peripheral arteries like radial artery. So this is how you check for the radial artery. Then there is something called brachial artery. So brachial artery is checked in the cubital fossa, the middlemost aspect of the cubital fossa. So you slightly flex the cubital fossa and try to feel the bicipital tendon. So you can check in yourself, try to feel your bicipital tendon. If you cannot feel the bicipital tendon, what you can do is you can ask the patient to flex his elbow against resistance. Try to flex your elbow. So when he's trying to flex his elbow against resistance, I can now his bicipital tendon is most prominent. And just medial to the bicipital tendon, you will find brachial pulse, right? So I can find his brachial pulse. Yeah. The same is true for other side as well. So take a handshake, make a handshake, slight ulnar flexion, slight arm flexion, and examine for the pulse. Okay, good. And if I want to find his cubital, I will not do something like this. I will not try to examine his brachial pulse using my right hand, because in doing so, my thumb will be in the lateral aspect, and there is no brachial pulse in the lateral aspect. And this is one common mistake that students do and land themselves in a very difficult position, right? So what you can do is, you can do something like this. So I use the left hand while examining his left hand and tap it just medial to the bicipital tendon. Thumb are not a very good sensitive indicator of pulse. Yeah, only during brachial pulse do I use thumb. If you cannot feel with thumb, you can also use your 3 fingers, just like how you did in the radial pulse. Okay, it's okay, right? Now, so these were the brachial pulse. Okay, now you can also do something called carotid pulse. So for carotid pulse, what you can do is you can ask the patient to look in the other side, and you can notice that this is the sternocleidomastoid and this is the midline, and in between the sternocleidomastoid in the midline, in between these two structures at the level of thyroid cartilage. So this is the Adam's apple, this is the tip of the thyroid cartilage. Just middle to the thyroid cartilage, you can feel carotid pulse. Okay, the largest pulse in our body is carotid pulse. For doing his left side, I will do once again. I will do the same. I will ask him to turn towards the right and try to examine his carotid pulse. Okay. So there are different theories which say that if you want to check the rate and rhythm of character, rate and rhythm of pulse, use radial pulse. If you want to check the volume of pulse, use larger pulses like carotid pulse and brachial pulses. Even that is acceptable, right? Okay. If sometimes peripheral pulses are not palpable, and still you want to find about something, gain a knowledge about the pulse in this patient, then go for a bigger pulses. If you cannot find radial pulses, if you cannot find dorsal spiritus, go for carotid pulses. Okay. So there is one branch of external carotid artery. Okay. So this is also known as temporal artery. So you can also check for the temporal pulses, right? So to check for the temporal pulses, go for 2 cm in front and superior to the tragus. So this is the tragus, this is the tragus, and 2 cm anterior and 2 cm superior to the tragus, you can find your temporal pulse. Did you find? So that is also important. Temporal pulse is important especially in one disease, which is called temporal arteritis. So there is an autoimmune disease typically seen in females of middle age, sometimes male as well, old age male, and in those cases what can happen is there is inflammation or vasculitis or narrowing of the temporal artery. And in those cases, temporal pulse might be absent. It is why is it life threatening is because if there is inflammation of the temporal artery, there is also inflammation in the ophthalmic artery as well. And if a person has temporal arteritis, he can also have occlusion or narrowing of the ophthalmic artery. And you can imagine if the ophthalmic artery is narrowed, the person will be blind. Right? That's why examining temporal artery is also very important. Okay? So these were the pulses of the upper part of the body. Then you can check for the pulses in the lower part of the body, which include femoral pulse, popliteal pulse, and posterior tibial pulse, and dorsalis pedis artery. Okay. So for femoral pulse, I will ask the patient. So you will ask the patient to be in around 120 degree or, if preferable, supine position. So if the patient is in supine position, what you can do is you can articulate or find the inguinal ligament or inguinal line. So for doing so, you need to find out the anterior superior iliac spine. So check on yourself where is your anterior superior iliac spine. Do you know what ASIS is? ASIS stands for anterior superior iliac spine. So find your anterior superior iliac spine, find your pubic symphysis somewhere around here, and in between the anterior superior iliac spine and pubic symphysis there is a ligament or line which is also known as inguinal ligament. Find the midpoint of the inguinal ligament, yes, and go around 2 cm inferior to the midpoint of inguinal ligament. So 2 cm inferior to the midpoint of inguinal ligament. Use in the vertical fashion. Find the femoral artery. Okay, so you can practice among your friends to find the femoral artery. So that is how you find your femoral artery. Okay. So, and to find out about the popliteal artery, ask the patient to flex the leg at around 120 degrees. So this is roughly around 120 degrees of flexion of the knee. And popliteal artery is very deeply seated in the popliteal fossa. You cannot palpate just by doing this. You need to hook your all 4 fingers very deeply. Yeah, so that your 2 thumbs are on the patella and the 4 fingers are posteriorly, and try to palpate very deeply. Okay, and so it might be difficult if the patient has extra layer of clothing. So try to do it by removing the clothing as much as possible. Okay. So one single most important thing for popliteal artery is 120-degree flexion. If you don't do 120-degree flexion, if you do it in 180-degree flexion, you might not find it. Okay, so 120-degree flexion, hook around both, use both your hand at once. Do not do something like this or something like this. Use both your hands at once and really try to feel it deep. Okay, so that is how you check for popliteal pulse. Okay. Middle malleus. So just go 2 cm behind the middle malleus, and once again use your 3 fingers and arrange it in vertical fashion. Yeah, and you will find the posterior tibial pulse. So this is one very consistent way of finding posterior pulse. There are various methods of finding the same pulse. The third you can do, one other thing that you can do is somewhere around the midpoint of the heel, from heel to the middle malleus, find a midpoint and palpate there. It basically means the same thing, right? Use this or this. Textbook says 2 cm behind the tip of the middle malleus in vertical fashion. So this is posterior tibial artery. Okay. Now, what you can do is you can also examine something called dorsalis pedis artery, the most terminal branch of the artery in the dorsum of the foot. For that, what you need to do is find the first wave space. You know what is wave space? The spaces between the two metatarsal bone is the wave space. So this is first wave space, this is second wave space, this is third wave space, this is fourth wave space. Okay? So find the first wave space and go as much proximal as you can, and you will feel the wave space will close. And there is a prominence, this prominence. Just measure this prominence at the proximal most part of the first wave space, you will find dorsalis pedis pulse. Okay? So that is how you do it. Also known as thromboangiitis obliterans. Okay, you might be studying later. ठीक sir? Then you need to see whether all the peripheral pulses are palpable or not. Sometimes in shock, in case of dehydration, he might have a good pulse here, but if you palpate the peripheral pulses, that may be absent. And if the peripheral pulses is absent, it means his volume status is not good. He needs IV, probably he needs an IV line to be put in and to be resuscitated with large amount of IV fluid. Okay. You also need to check something called radio-radial delay. Okay, so sometimes there can be a localizing disease. Let's imagine there is a patient whose left subclavian artery has a stricture or stenosis. So maybe there was a patient, he was admitted to the ICU, he stayed in the ICU for 3 months because of some road traffic accident, and during that time there was a central catheter, a central line put in, and the tip of central line usually lies in at the junction of the subclavian vein, right, and subclavian and internal jugular vein. And or sometimes the patient might have an arterial line put in. If there is an arterial line that is put in during an ICU, if there is long-term presence of this catheter, can cause irritation in that arterial line, and then artery can get stenosed. Then what will happen? The pulse on right side will be normal, whereas pulse in the left side will be two things: smaller in volume, hypokinetic, as well as delayed compared to this pulse, because the wave takes more time to pass the stenotic area. Okay, so what you can do is you can check both the pulse at once. So that was, if you wanted to check pulse only in one hand, then there was a technique of handshake. So do a handshake here, check pulse here. Okay, now stay here, don't leave this hand. I am still feeling the pulse and trying to feel the pulse in this. And I can notice both the pulses are hitting my fingers at the same time. So there is no radio-radial delay. And both the pulses are of same volume. There is no radio-radial delay. That is to say, from his heart to his right and left radial artery, it is taking almost the same time to reach here. So there is no radio-radial delay. Okay? There are some conditions like subclavian artery aneurysm, subclavian artery stenosis, coarctation of aorta proximal to left subclavian artery. Right? So coarctation means abnormal dilatation of aorta that is proximal to left subclavian artery. In such a condition, what can happen is there can be a delay between the two pulses. Okay? The same can be done by comparing the radial pulse and femoral pulse, and that will be called radiofemoral delay. So if there is a radiofemoral delay, that means the circulation in upper part of the body is normal, whereas circulation in the lower part of the body is stenotic or narrow. That means there is some kind of pathology in the part of aorta that lies in his abdomen. The example of which is abdominal aortic aneurysm or abdominal aortic atherosclerosis. or abdominal aortic dissection, anything, any pathology in abdominal aorta will have normal pulse in the upper extremity, whereas diminished pulse in the lower extremity. Is that right? Okay, so that was radioradial delay, radiofemoral delay. We talked about character, we talked about volume, we also talked about rate and rhythm, and also check whether the peripheral pulses are palpable or not. So in exam, how will you present your findings? You did all this examination, and how will you present a normal finding? So you will say, my patient's heart rate or pulse rate is around 80 beats per minute. Yes, it is normal in character, it is regular in rhythm, it is normal in volume, also known as isokinetic. It is normal in volume. There is no radioradial or radiofemoral delay. All the peripheral pulses were palpable. And if you say all these things, it means his pulse was completely normal. So if there is a patient of atrial fibrillation, you will say, so my patient's pulse rate was around 150 beats per minute, and it was irregular in rhythm. Okay, and it was the pulse was hypokinetic, and there was and all the peripheral pulses were normal or palpable. Okay, so these are one example of physiological pulse and one example of a pathological pulse, and that is how you present. Do not present like rate 70 regular hypokinetic. So don't remember like that, right? Do not do it in a table wise manner. So use your language. Okay, so that is all about pulse. Any question? Any question? Anything new that you studied or found? Anything that I did not cover? Okay. So after pulse, we will move to blood pressure. So how to check our blood pressure? Blood pressure is very important. So what is normal blood pressure? So systolic blood pressure of 120 millimeters of mercury, and diastolic blood pressure of 80 millimeters of mercury. So lesser than that, it is considered to be a hypotension, or more than that, it is considered to be a hypertension. So if someone's blood pressure is 122 by 88, what is it? Hypertension? So normal. So to call someone a hypertensive patient, his blood pressure should be, so latest guideline says it should be more than 130 systolic blood pressure and 90 millimeters of mercury diastolic blood pressure. Okay. So for checking blood pressure, there are few prerequisites. You cannot check blood pressure of any patient anywhere. There are few prerequisites that must be fulfilled before checking our blood pressure. The first and foremost most important thing is the patient should be well rested. So the patient came hurriedly to your clinic and you wasted no time in taking blood pressure. It will be, of course, it will be a higher, right? And that will be a erroneous or false blood pressure reading. So whenever patient comes, make sure the patient has at least ideally 30 minutes, and if you are in a hurry, at least 5 to 10 minutes of rest. So after 5 to 10 minutes of rest, when his heart rate has returned back to normal, yes, then another second prerequisite is he must not have smoked, because as Pulkit already said, smoking or taking coffee or tea can increase your pulse rate as well as your blood pressure. So he should not have smoked in last 30 minutes. He should not have taken tea or coffee in last 30 minutes. So make sure. So ask the question. So तपाईं अहिले हिँडेर आउनुभएको हो, हिँडेर आएको तपाईले यहाँ एकछिन विश्राम गरेको कुरेको कति भयो? 1 घण्टा. So he has rested, right? And then तपाईले अहिलेको गतको आधा घण्टामा चिया कफी चुरोट के खानु भएको छ? छैन. So this is how you ask. Okay, so you ask and the prerequisite is complete. So another very important prerequisite is the patient must be either sitting or supine. If the patient is an ICU case, the patient cannot get up, the patient must be supine. Okay, and patient must be sitting. In sitting also, it is very important that while he is sitting, his legs should be touching the ground. So imagine him sitting here. If he is sitting here, his heels will not be touching ground. Then what will be happening is the weight of the leg will be pulling the thighs. When that happens, the weight can itself cause the arteries to get obstructed, and there will be a abnormal blood pressure reading. So if the patient is sitting, his legs should be supported by the ground. So the legs should be touching. The feet should not be dangling. It's very important. Another thing is, while he is sitting, his back should be well supported by the back of the chair. Patient cannot sit like this while examining blood pressure. If the patient sits like this while examining blood pressure and his back is not supported by the back of the chair, he is using his muscles of his trunk. And if you are using muscles of his trunk and it is in under contraction, 1 second the blood pressure reading can be erroneous. So make sure the patient is sitting, the patient's back is well supported, right? And the hand of the patient is at the level of the heart. Okay? So when the hand of the patient is at the level of the heart only, then you need to calculate or measure the blood pressure. Okay? So after doing that, so this is sphygmomanometer. Okay? So within sphygmomanometer as well, there is a certain portion or certain area which has bladder. So this area has bladder. If I inflate it, only this area will be inflated or cuffed up. Okay? So make sure these two tubes. So keep your hands like this, slightly on reflection. So these two tubes, ideally, the arm and forearm must be exposed. Okay? But for the patient's privacy right now, I am not doing it. Everybody says that. Everybody says ideally and never does anything ideally. Right? So we have also learned the same. So there is an indicator within the BP curve. So this is called artery. The artery must be at this position. Okay, so his brachial artery is here. So this should be somewhere around here. Okay, and it depends upon the cuff. Some companies' cuffs indicator is somewhere around here, in between the two tubes. Okay, and some companies' indicator is somewhere else. Okay, so if there is an indicator for artery, keep that indicator just at the brachial artery, and then wrap the BP cuff. Wrap it in such a manner that it is neither too tight or neither too loose. You can just insert 2 fingers, not more than that. Okay? Then you say that it is adequate. Then finally, this is the meter, right? So this is an analog meter where you will check for the blood pressure, and this should also be at the level of his heart. So that's why there is a clip that is given to hold it here. Okay? Sometimes in dire situation, if you don't have, you can also keep it in the table, but there will be some abnormality to the line. So it's best to hook it around here, something like this. Okay? And now there are 2 methods of checking for blood pressure. There is something called palpatory method and there is something called auscultatory method. For palpatory method, what I will do is I will palpate his pulse. Okay? And then I will gradually inflate the BP curve. I can still feel his pulse, and the BP curve is being inflated, the pressure reading are going up and up. So it is at 40, I can still feel his pulse. It is at 80, I can still feel his pulse. And when I went to 160, I cannot feel his pulse. So slowly I will decrease it. So I can feel his pulse at 110 millimeters of mercury. Okay, so this was estimation of blood pressure by using palpatory method. The drawback of using palpatory method is you can only estimate the systolic blood pressure, the higher blood pressure. The blood pressure at which the radial artery becomes just palpable is called systolic blood pressure. Okay, and you must always do a palpatory method followed by auscultatory method. Because if you do directly an auscultatory method, you might calculate a false blood pressure reading because of something that is called auscultatory gap. Okay, yes, sir? So by palpatory method, I found that his systolic blood pressure was around 110. Now I know up to what point should I inflate this BP cuff. So always go 20 millimeters of mercury above the systolic blood pressure that you found out by palpatory method. So palpatory method was 110. So I will inflate this cuff up to 130 while doing a auscultatory method. So wear this, okay, and then keep the check whether it is on the diaphragm mode or bell mode. Okay. Okay, and keep the diaphragm on the exact spot where you check the brachial pulse. So on just medial to the bicipital tendon. So somewhere around here. Okay. So somewhere around here. Right, sir? And then inflate the BP cuff up to 130 or 20 millimeters mercury above the systolic blood pressure that you found by palpatory method. Okay, so on auscultatory method, I found that the appearance of throat cough sound is at 120 millimeters of mercury, and the disappearance of throat cough sound is at 80 millimeters of mercury. So if the blood pressure is perfectly normal, that is around 120 millimeters of mercury systolic and 80 millimeters of mercury diastolic. And that is what you do. That is how you present. So if somebody asks what, okay, you did your blood pressure measurement, okay, present me your finding. So you will say his blood pressure is 120 millimeters of mercury systolic and 80 millimeters of mercury diastolic. Do not say his blood pressure is 120 by 80 mmHg. That is a layman's term. Okay? Sir? After this, what you can do is you can also check the blood pressure in the other hand as well. Because if there is subclavian artery aneurysm, subclavian artery stenosis, coarctation of aorta, any disease, his blood pressure reading on the left side will be decreased. Okay? Suppose his blood pressure was around 160 by 100 millimeters of mercury. Then what would have been the diagnosis?
Stage 2 hypertension.
Okay, so everybody says it will be a hypertension. But that is not the case. That is not how you diagnose a hypertension. Remember, this is a clinic setting. He came to me for the first time. Maybe he's anxious. Maybe he has something called white coat hypertension. Maybe his heart rate always pumps up whenever he sees people in white coats. Right? So for the diagnosis of hypertension, there is one very important criteria, that is his blood pressure should be elevated in his physiological setting. He is in a foreign setting right now. He's in my clinic, right? So what you need to do is you need to make sure that you take at least twice daily blood pressure readings for at least 1 week. And if you find that his blood pressure is consistently high in all those findings, then only do you diagnose him with hypertension. Okay? A single high blood pressure reading is not diagnostic of hypertension, except it is a very high blood pressure reading, more than 160 by 100 millimeters of mercury. Then you can say it is a hypertensive emergency or hypertensive urgency. Okay? So that is how we check for blood pressure. Right? Okay. So the third thing that we will check for today is respiration. So respiration is very easy. Okay. So what you need to do is you need to observe this patient, preferably tangentially, so that I can see his chest moving up and down. If I look him from the front, I might not notice. So preferably even examine the chest tangentially. The patient is lying in the ICU or supine, so go to at the level of the patient and see for the chest moving. In clinical settings, in clinics or clinical setting, it is said that if I don't stop speaking to him and suddenly all of a sudden start looking at his chest, he will become anxious, and his physiological rate of respiration will be high. And what I will be measuring will be a false value. It is also known as Hawthorne effect. The change in your behavior whenever you notice that someone is noticing you, that is called the Hawthorne effect and Hawthorne bias. HAWTHORNE, Hawthorne effect. Okay, so I must make him comfortable while I check for his respiration, right? I cannot tell him that I'm checking for your respiration. Once again, that will bring in a bias. So what I can do is I can talk to him. I can make him comfortable while I look for his respiration. I count for 1 full minute. Okay, so I will notice the time and then I will start talking to him. And while I am talking to him, I am measuring the number of times the chest moves up and out. And that is how you look for respiratory rate. Okay, is that normal? Okay. Now, so after looking for the rate, you will also look for, while you are looking for the rate, you will also look for any irregularities in respiration. Is the rhythm of respiration normal or not? So there are some abnormal rhythm of respiration as well, which are known as Kine-Stokes breathing, CHYNE, Kine, STOKES, Kine-Stokes breathing, as well as Biot's breathing. So suppose everybody imagine a patient in ICU after road traffic accident, severe extradural hematoma in the brain, so much so that the pressure in the brain is very high and it is causing the temporal lobe of the brain to herniate through the foramen magnum, the opening in the skull. What will happen is that the herniated part will cause a compression of the brainstem, and in brainstem there is something called respiratory center, and if there is a compression of respiratory center, his respiration will become irregular. So that is Kine-Stokes breathing. If it is very severe, if there is a complete compression of the medulla, then his breathing will become erratic, and that is called Bytes breathing. Okay. If there is a patient of diabetic ketoacidosis, right? If there is a patient of diabetic ketoacidosis whose body has large amount of H plus ion, right? Acidosis, then what will he do? He will do a very deep and fast breathing. So this is something that is called Kussmaul's breathing. Deep, fast breathing is called Kussmaul's breathing, which is seen in diabetic ketoacidosis, and it will be a compensatory mechanism. It is a protective mechanism, because if you breathe fast, what will happen is it will throw out all the carbon dioxide, and if you throw out carbon dioxide, you do not form H plus ion in your blood, and you treat your metabolic acidosis with respiratory alkalosis. Yeah, so that is also one of the respiratory findings. So Kussmaul breathing, Kain-Stokes breathing, Bytes breathing. So these are three important pathological breathings that you must be aware of. Okay, so that is all about respirations. Besides that, you can also check for whether the respiration is thoraco-abdominal or abdominothoracic. Nowadays, this distinction is not important, right? But in previous times, our physicians used to be very scrutinized about whether the breathing is thoraco-abdominal or abdominothoracic. But nowadays, you can survive your medical school without knowing about it as well. So what is thoraco-abdominal? So thoraco-abdominal is, are you breathing using your diaphragm, or are you breathing using your intercostal muscle or abdominal muscle? That is what, there is a difference between thoraco-abdominal and abdominothoracic. So imagine a female. A female has a chance that she will become pregnant someday. And if she becomes pregnant, she will have a very huge uterus as well as fetus. So can she use her diaphragm to breathe? No. So she will use her intercostal muscles. So if you breathe using your intercostal muscles, you can see the visible chest that is moving out, right? So there is minimum movement at abdomen, but maximum movement at the chest. So this is thoraco-abdominal. So wherever the movement is highest, the name will come first. Thoraco-abdominal, the maximum movement is at the level of thorax. Okay, but we men breathe using our abdomen or our diaphragm. So if you breathe using your diaphragm, so during each breath your diaphragm comes down or flattens, the abdominal pressure increases and your abdomen moves outward. So if you completely relax, you will breathe something like this. So your abdomen comes out, whereas your thorax remains at the same place. Right? If you are anxious, if you are running from somewhere, then you will do thoraco-abdominal. Okay? If you are well rested, comfortable, then you will do abdominothoracic. If you are a female, you will do thoraco-abdominal. So that is a finding that some physicians note, but doesn't mean anything. So if you can skip it as well. If an examiner asks what is thoraco-abdominal, what is abdominothoracic, then you can say the answer. Okay? So that is all about respiration. Finally, what you can do is you can also check for temperature. So for temperature, what you need is a thermometer. So there are four places where you can use check for temperature. So the oral temperature, there is a oral temperature, there is an oral temperature in the ear canal, right? There is a axillary temperature, and there is something called rectal temperature. The most accurate for core temperature is rectal temperature. Okay. So there is a debate between rectal temperature and oral temperature, but for now you can say rectal temperature is most accurate for core temperature. Okay. So nowadays there is only digital thermometer. Previously there used to be a mercury thermometer, so you don't need to worry about that. So the digital thermometer, press it and keep it in under the axilla. Make sure the axilla is not wet. If the axilla is wet, there is lots of hair, there will be false reading. So if the patient has fever and his fever has recently come down, he has sweated a lot and it will be wet. So wipe the wet using a tissue, right? And after that, keep the thermometer and try to adapt it. And after 1 minute, it will beep and it will show you the temperature of this patient. Okay? What is the normal temperature of human body?
36.7.
So there is one single reading that is normal. Anything left to it is hypothermia. Anything right to it is hypothermia.
No. Range.
So in medical school, there is always a range for everything. So what is the normal range of body temperature? So there are different books have different findings, but anywhere from 36.8 to 37.2 is a normal finding. Okay, beyond 37.2 it might be hyperthermia or fever. Less than 36.8, it might be hypothermia. Okay, right? For the definition of hypothermia, the temperature must be less than 35. Okay, so that is how you check for temperature. In pediatric patients, where do you check for temperature? Rectum. Because pediatric patient cannot keep thermometer, or they may bite into the thermometer, right? Or pediatric patient may not follow your command and adapt their arms. So rectal temperature is an adequate temperature in pediatric patients. Okay, so finally, for the last thing that you need to do is measure something which is called jugular venous pressure or jugular venous pulse. So there are two jugular veins in the neck. There is something called external jugular vein and there is something called internal jugular vein. Internal jugular vein lies just beneath the sternocleidomastoid, beneath or deep to the sternocleidomastoid. It cannot be seen visibly from outside. Whereas external jugular vein can be easily seen beneath the skin, right? So, because his internal jugular vein is in communication with his right atrium, any pressure changes that occurs in his right atrium will also cause a change in the column of blood in his internal jugular vein, and that is all that you see. So if a patient has long-term COPD, pulmonary hypertension, or right ventricular hypertrophy, or tricuspid stenosis, tricuspid regurgitation, or pulmonary stenosis, any obstruction from the right atrium to the lungs will cause the pressure to increase, and in such condition the right atrial pressure will be high. And if some person's right atrial pressure is high, the column of blood that lies within the internal jugular vein will also be high, and the highest part of pulsation will be somewhere around his ear. Okay, and if his JVP is low, that is say his right atrial pressure is low, then the column of blood will be oscillating somewhere around here. So in that case, what you need to do is, we don't have all of the equipments right now, so maybe I will show some other day. So ask the patient to turn slightly on one side and shine a light directly from the behind the patient. Okay, so shine light behind the patient so that the light falls tangentially and light does not fall head on. So this is how light falls head on. If light falls head on, I will not be able to see the movement of veins. So make sure the light falls tangentially, and then notice the pulsation in the neck. So there is one pulsation I can see. The moment I see a pulsation, I try to feel it, and if I can feel it, it is not a jugular pulse. It is a carotid pulse. So carotid pulse is better felt than seen, whereas jugular venous pulse is better seen than felt. So if you are seeing a pulse and if you try to feel it and you cannot feel it, then it is a jugular venous pulse. Jugular venous pulse has 2 beats, okay, whereas carotid pulse has only 1 beat. Carotid pulse is outward towards the skin, whereas jugular venous pulse is upward and downward. So these are some differences of how you will differentiate between jugular venous pulse and carotid pulse. Okay, make sure the room is dark. Use a tangential light. Ask the patient to lean backward so that with the ground he makes a 45-degree angle, and then measure the pulse. Find the highest point of pulse, right? And at the sternal angle of Louis, make a scale or keep a ruler that is perpendicular to the ground, and use another scale that is perpendicular to this scale. And at whatever point this scale touches, calculate the centimeters, right? And his jugular venous pulse is that 1 centimeter above the sternal angle of Louis. So suppose there was a vertical scale around here and a horizontal scale around here, and it coincided at around 2 centimeter, then his jugular venous pulse is 2 centimeter above sternal angle of Louis, or 7 centimeter above right atrium. Because if a person lies in 45-degree reclined position, his sternal angle of Louis is almost always 5 centimeter above right atrium. So you can demonstrate or say that his jugular venous pulse is either x centimeter above sternal angle of Louis or x plus 5 centimeter above right atrium, because sternal angle of Louis itself rises at 5 centimeter above right atrium. Is that okay? So these are all the vital signs that we look for in any patients. These vital signs are very vital in understanding whether the person has any pathology or any disease or not. Okay? Okay, thank you.